when they end up here in the emergency room, or if on life support, for months, if not years to come. That's an actuarial reality.
And how many does that happen to?
A lot.
Yeah. So, too bad for them. If they make that choice, that's their life.
No. They don't make the choice because they might have made the choice to get on that motorcycle. They don't make the choice of what end of life looks like in the hospital if there's a glimmer of hope that they might be revived. We pay for it in our own health insurance plan. And let me just say something, sir. You need to visit your local agent and talk to them as to how risk is parceled out through insurance plans. Now, I hope we can all agree on this. I'll be right with you. Ma'am, I'll be right with you. Let me just say a couple of things. What we have agreed to here is essentially this: universal coverage, and you need a mandate to get there. You need a mandate to get to universal coverage. Conservative Republicans agree with Democrats on that issue.
Save money.
Speak for yourself, but not others.
Let me just make a couple other points. I hope we would all agree that you don't want the issue to continually be raised of a pre-existing condition. And you know, the other thing I hope we can agree on, you don't want to be one paycheck away from the end of your health care plan through layoff or loss of job.
Would you like to hear it?
You want to be able to continue your health insurance.
You can.
So I'm happy, believe me, I'm happy to listen to what you have to say.
So thank you, Congressman Neal. So in scanning through the cards, I see at least 5 cards from different individuals with different versions of the question about whether or not individual congressmen would feel that the coverage that is being offered in the health plan would be sufficient for them and their families. So I think that's
the public plan we're talking about.
Let me explain how this works. All right, nobody is forced into a public plan. If a public plan, I'm answering the question. If the public plan makes sense for me and my family, I will go into it. Why would I any more than you will commit to it? The reality is this notion that somehow members of that we should commit to a health insurance that's being put together. You're not being forced into that. If you listen and you read the bill, no, you didn't, because the bill gives you the choice to be able to keep the insurance you have, pick another insurance, or if you like the public plan, you can go into it. You are not forced into the. That is true. It is true. No. Well, first of all, it is true. Well, it is true, and we can argue over what's not in the bill all you want. But the answer is all of us should do what is in the best interest of ourselves and our family. And if that means going to the public plan, I'll go into the public plan.
So
The plan hasn't been written yet, ma'am.
so there are. So
no one is forcing you. First of all, ma'am, are you on Medicare? Are you on Medicare? I'm asking. No.
So there.
If it makes sense for me and my family, I will.
Will you be?
Yes. If it makes sense for your family, yes.
You know what it was presented, but it was voted down.
No.
You won't be in that health.
No, it wasn't.
So there.
There are, let me just,
What do you mean it was voted down?
let me try to clear the air about something if I can. My health care plan, so that you know, is the same plan that is enjoyed by 7 million federal employees. It is the purchasing power of that federal plan that helps to keep costs down. There is a menu within the plan that you choose at different intervals of your life. There are times when you need more insurance because if you have young children, and then that pressure eases, you get a little bit older before you move into the area of need of Medicare. There are 7 million, when I hear people say, we want the same plan that Congress has, I agree. But it's not a special plan, it's Blue Cross Blue Shield. That's what yeah.
So there are a few questions about Medicare, and but I want to read one that has a personal stint. So this is addressed to Congressman McGovern. Right now, I am suffering with the Medicare prescription donut hole, which means I have to pay 100% of the cost of my medication. Will the new health bill cover the cost of prescription medications, so I won't have to go without for 6 months of the year?
Yes. I'm going to tell you how we're going to pay for it. We're going to change the Bush language in the prescription drug bill, which says that, please, you want to have more questions, don't interrupt. With the prescription drug bill that the president put forward said that the Secretary of Health and Human Services would be prohibited from negotiating en bulk lower prescription drugs on behalf of Medicare beneficiaries. One of the reasons why the VA can offer cheaper drugs to veterans is they negotiate en bulk. We're going to give the Secretary of Health and Human Services that ability, and that will save billions and billions of dollars, which will enable us to close the gap.
By the way, that last question was signed. I'm not saying the names of any of the people who signed it, but that was signed. That was a question written here by one of you just now. I also have a question from a student, actually from a graduate student who I won't identify, but it goes as follows. The cost of malpractice insurance has been steadily rising over the last few decades. Wouldn't capping malpractice lawsuits help lower the cost of medicine?
That needs to be part of the final discussion here. Yes, that needs to be part of the final discussion.
Even though Bush started that?
Why is it now? Why is that so hard to put in now?
So
It could be in the Senate version when it comes back. It's not in the House bills. It is not. But that is a part of the discussion that needs to take place as we move along. Yes. Yes. That is something we will take a look at when we get to the final stages. That is a reasonable position that you've offered, ma'am.
Do you favor tort reform?
Pardon?
Do you favor tort reform?
I have favored mediation reform as it comes to tort reform, yes. I think we need to move past the two vehicles that we're using that are so polarized on both sides. One saying you can never do this and the other saying you can never do that. I think we need to find some common ground with mediation on that issue.
all right. We have another question. Again, I think it gets to how much we can afford. I can attest this was not written by one of our emergency room physicians because this person doesn't understand EMTALA law as it exists. But how can we add 50 million people on top of the existing healthcare system, doctors, hospitals, and facilities? Something has to give, and it talks about cost of care.
Half the people that end up in the emergency room probably don't belong there. I think there's a general agreement on that. The result of which is we all pay the cost, again, sir, despite your difference of opinion with me on that, we all pay the cost through our own health insurance plans because it's passed through to all of us. And the idea simply would be if those individuals, who by the way will be encouraged to purchase private or a public option health insurance plan, then in fact those individuals would have health insurance. If they all have health insurance, then it takes some of the pressure off the risk issue that I raised earlier about how those costs are passed on to the rest of us. It's kind of basic economics.
And I just say one other quick thing. People have raised this issue to me about the public plan. Somehow it's out there that the public plan is free for anybody who's in it. It's not. You have to pay to be in the public plan. If that's what you want, you pay to be in it. So it is not free. It's not
Are illegal immigrants still going to be ending up in the hospitals?
Illegal immigrants are not included for health insurance, ma'am. I want to assure you of that. They're not in the bill.
What they're doing now, sir, is that they're showing up at the hospital.
Absolutely.
I've been in one sitting 5 hours waiting.
Ma'am, I'm going to tell you.
So what's the change? How is that going to change?
Well,
That's going to still be a big cost to us.
The bottom line is
So they should be
a
included too,
small-
you're
first of all-
right, they should be included too, I agree.
That should be important.
Put the camera away, ladies.
I'm going to give you one quick answer to that. I agree with you. We need to discourage and we need to enforce the law. And at the same time, I'm going to give you an answer that the Sisters of St. Joseph would have given me, my colleagues, and that is if they end up at the emergency room and they're near life's door, they should be cared for. Absolutely.
This next question also represents many of the cards, and thank you, Congressman. You're answering these I think you're getting to all these points. There has been recent heated discussion. This represents about 5 or 6 cards, but it's well stated. There's been recent heated discussion regarding the possibility of speaking with patients speaking with their physicians on end-of-life and advanced care planning choices. Misperceptions have gained speed. Could you clarify what is in the bill regarding the option to discuss choice with doctors and the position policymakers have on it. So the issue of end-of-life care.
First of all, doctors talk to patients all the time about that subject. Secondly, there is nothing in the bill that is mandatory that requires that doctors have these discussions with their patients. There's nothing mandatory in the bill. If you read the bill, there's nothing mandatory in any of the bills. What it says is that doctors can get reimbursed for those discussions, if they occur. So this notion that, I mean, we've been getting calls that we're going to be forced into every 6 months having discussions with our doctor about end-of-life issues, that is just a complete fallacy. So there's nothing in this bill that is mandatory at all about that area.
425 to 430.
Yeah, I did.
Mr. McGovern, essentially, Mr. McGovern's correct in what he said, that this is an option that will be provided to you if you desire it, but that conversation that you wish to have with your physician, that's up to you. There is no mandate for you to have that conversation with your physician. You make that decision. I had a funny moment because the subject came up with one of my children this week, and I reiterated to him, he's 28, and I said, hey, Brendan, he said, well, Dad, tell me about this. So I explained it to him, as we've explained it here, and I said to him, Brendan, I want to make something very clear. No machines for me. I want that understood. And without missing a beat, he said to me, you don't have to worry. He said, I've been talking with your other children. My point on that is, I want that clear. I don't want to languish on a machine someplace. I don't want you caring for me at a time when it's taxing a family and taxing the healthcare system if there is no hope that that's going to be reversed. And I think we all would be better off if we had that conversation as members of the American family in our own families.
I have a question from someone who identifies themselves as a primary care physician. Says, thank you for coming. I think that probably needs to be read. As a primary care physician, one of the biggest areas of waste is efficiency waste, administrative costs that do not enhance quality, that reduce access, and increase cost. It is estimated that a 10% reduction in these costs would decrease $500 billion in 10 years. So if you want to address
this is an area which I spent a lot of time in this legislation. I do not want to farm out the issue of Medicare reimbursements to an independent party. There is an element that is moving toward a discussion and direction of what they call value-based care. I think that what doctors decide is value-based care. Now, we reached a compromise in this language. And the compromise that we reached in this language is, rather than to create, this is a very important question that this student has raised. The compromise we reached is that rather than creating a super med pack, which I think doctors vehemently object to, because they think that it would interfere with the decisions they make as they relate to their patients, at the same time, I was able to stave off the opposition on this. The Institute of Medicine, the IOM, they will do an independent study. All hospitals will be held harmless for 2 years while we get there until that study is concluded, and then they will come back and they will make suggestions. Now, I want to say this because I opened with this statement. I want to get back to it because I think it's that important. Not only are our hospitals in Massachusetts, and I've made this argument, by the way, to friend and foe, not only are our hospitals in Massachusetts the envy of much of the rest of the world, but they are now the engines of economic growth. The great jobs that are created here in Massachusetts through our healthcare system. In addition to which,
6 months wait to see a specialist.
right?
When
Okay.
is your question
That's
coming up?
legitimate.
When is she getting
Legitimate.
any questions answered? I'd like to know. I wish she'd just stop.
But at the same time, with the hospitals that we have, we also benefit from a couple of obscure parts of Medicare. One is called graduate medical education, GME. Now, graduate medical education means that money goes toward training our doctors, which again are arguably the best in America, if not the world. So Medicare, as part of that conversation that I referenced, it helps to pay for the training of our very good doctors. Lastly, NIH and the National Science Foundation, they give out extraordinary grants. Anybody who's familiar with what the NIH does every day, you would be impressed. We attract, because we have these great teaching hospitals in Massachusetts, we attract a disproportionate number of dollars on that basis. We need to be mindful of that as this debate and discussion proceeds.
Hey, just one more point on the issue of efficiency. I mean, this whole move toward health IT, putting your medical records, creating electronic medical records, is actually a way to save a whole boatload of money. It's estimated that for every healthcare dollar we spend, well, 40 cents of it goes to administrative costs. If you could save just a few cents of that 40 cents, that's hundreds of billions of dollars. And electronic medical records is one way to help reduce medical errors and also reduce a lot of paperwork that is very, very costly. And it could save, again, hundreds of billions of dollars.
Okay, here's another very personal card here. It says, I'm 81. I